Hi, my name's Nicola Dunbar from the Aged Care Quality and Safety Commission, and welcome to this second in the series of webinars jointly held by the Commission and the PSA. I'd like to begin by acknowledging the traditional owners of the lands on which we're all meeting tonight and pay my respects to elders past, present and emerging. In our first webinar, we talked broadly about the Commission and some of the changes that are happening in aged care with the aged care reforms that are particularly relevant for pharmacists. Tonight, we're going to focus on one particularly complex example around restrictive practices and informed consent. Thank you for the questions that you submitted in the last webinar. We didn't have time to deal with them at the time, but we believe they've all been answered. But if you have submitted a question that's been overlooked, please send it through to the PSA and it will be sent on. If you have questions tonight, please put them through the chat function. And as I say, if we don't get to them, we will come back to them and follow up with answers for you. We have another excellent group of speakers on our panel tonight, and I'll introduce them as we go through this session. So we might just move to Melanie. Melanie Roth is the Commission's Chief Clinical Advisor. And Melanie, can you explain what restrictive practices are and how the definitions have changed recently?
I can, thank you very much. Approved providers of residential aged care have specific responsibilities under the Aged Care Act of 1997 and the Quality of Care Principles of 2014 relating to the use of any restrictive practice for consumers in residential aged care and short-term restorative care in a residential setting. And these Quality of Care Principles were amended, taking effect from July of this year, to tighten the requirements and make them more detailed and explicit. So to start off, there's a hot off the press educational, very short animation, which I want to play now to set the scene, but it is available if you ever need to play it in any of your education as well.
Everyone in aged care has the right to be safe, treated with dignity and respect, and receive high-quality care and services. That's why it's important you understand the rules around restrictive practices. In aged care, restrictive practices limit your rights or stop you from doing what you want to do. A restrictive practice can be chemical, using medication that restricts your movement or affects your ability to make decisions. Environmental, restricting or limiting your movement, like securing doors to prevent access to outside areas or moving mobility aids out of reach. Mechanical, using a device like bed rails, low beds or clothing to prevent you from moving. Physical, using force to prevent, restrict or subdue your movement. Seclusion, putting you alone in a room or physical space where you can't choose to leave without help. Inappropriate use of restrictive practice is very serious. Before your provider can use a restrictive practice, they must have an approved health practitioner assess you and discuss strategies with you. Document any changes in a behaviour support plan. Ensure that restrictive practices are only used as a last resort and in the least restrictive form after all other strategies have been tried. Obtain documented informed consent from you or your substitute decision maker. If using a restrictive practice, staff and your provider must monitor you for signs of decline, distress or harm, and regularly review the use of the restrictive practice to remove it as soon as possible. In an emergency, the rules are different because you or others may be at risk of harm without the restrictive practice. Remember, restrictive practices must only be used as a last resort and in the least restrictive form. They should never be used as a punishment. If you are concerned about how restrictive practices are being used on you or your loved one, contact the Aged Care Quality and Safety Commission. Let's stay safe together.
So I hope that set the scene for you, but I just wanted to go back to what's changed in the legislation. And one of the things is that the terminology has been updated from the word restraint, where it used to be either chemical or physical restraint, now to use the term restrictive practice, which aligns with the terminology of the NDIS. A restrictive practice is now defined to mean any practice or intervention that has the effect of restricting the rights or freedom of movement of a residential care recipient. The quality of care principles, as you saw, now define 5 types of restrictive practices. These are chemical, mechanical, physical, environmental restraints, and seclusion. Amendments also replace the definition of consumer representative with the term restrictive practice substitute decision maker, and that's to avoid confusion with some of the state and territory legislation where the previous term meant different things. And that's to avoid confusion. A restrictive practice substitute decision maker is a person or body that has the authority under state or territory to provide consent on behalf of a consumer who is unable to consent for themselves. The amendments also introduce compliance notices and civil penalties in response to a breach of restrictive practice responsibilities. And the amendments align with the operation of the Serious Incident Response Scheme that we discussed last time. It aims to reinforce the rights of aged care consumers in making decisions about their care in accordance with the user rights principles and the Charter of Aged Care Rights. Providers must ensure that consent has been obtained in accordance with the state and territory requirements and subsequently recorded in the patient's record. The use of restrictive practices must be detailed now in a behaviour support plan, and that had to be in place by the 1st of September of this year. There was a delay between the new amendments and the requirement for the behaviour support plan to allow providers time to develop a behaviour support plan. The alternative behaviour support strategies must be used before considering any form of restrictive practice, and these interventions must be documented in the behaviour support plan, including actions taken leading up to the use of restrictive practice and any strategies used to prevent the need for them. Consumers with restrictive practices in place must be monitored for signs of distress and harm, and there must be a record of why the restrictive practice is necessary, the frequency and type of observations required, the comfort and safety of the consumer, and the ability to maintain activities of daily living such as toileting, hydration, nutrition, social interaction, etc. They give greater clarity to providers on the responsibility for prescribing practices and obtaining informed consent, including the ongoing use of restrictive practices, their duration, their frequency, and the intended outcome. Mechanical restraint involves the use of a device to prevent, restrict or subdue a consumer's movement. Examples of this would be a lap belt that ties someone into a chair, or a princess chair that somebody can't get out of, or bed rails in some situations. Restrictive clothing. Physical restraint is an intervention that involves the use of physical force to subdue a movement of their whole person or part of their body. Usually this would be in the context of preventing somebody from doing something or to enable care. Environmental restraint really speaks for itself, but it restricts a consumer's free access to all parts of their environment, including items and activities. So it includes their room, common areas within the service, the common grounds outside the service, so access to the community. Doesn't include other consumers' rooms. Seclusion involves the solitary confinement of a consumer in a room or a physical space where voluntary exit is prevented or not facilitated, or it's implied that voluntary exit is not permitted. So examples would be placing someone alone in a space or room from which they cannot exit, or from which they cannot see or interact with other people, where they can't access a call bell or a walker, or imposing a timeout. Seclusion is an extreme form of restrictive practice and should really never, well, hardly ever be used, but certainly not in a punitive way. And the final thing I want to say is that there are different provisions for the use of restrictive practices in an emergency where there's an immediate action needs to be taken to prevent instant risk of harm. Thanks.
Okay. Thanks, Melanie. So Melanie has given us an overview around 4 of the types of restrictive practices. I'm going to start with Leonie Anderson, who joined us for the first webinar. Leonie's from the Commission, and she's going to start by telling us a bit about why there's an increased focus on restrictive practices in aged care. Thanks, Leonie.
Thanks, Nicola. Thanks, everyone. Apologies for the glitch in the matrix. Excellent. So I was talking about some of the reviews that were happening for restrictive practices that have led to the changes that Melanie's been talking about. We had the Carnell-Patterson report, which led to the establishment of the Aged Care Quality and Safety Commission as a recommendation. Then there was a secondary inquiry from Parliament into aged care quality and safety, which included a review of legislation and regulation in aged care. In addition, changes regarding the use of restraint were made to the quality of care principles, which Melanie spoke about, and these are earlier than the ones that have just been described. And there was a requirement around that those changes made needed to be independently reviewed within a 12-month period. In addition to that, we had the Royal Commission into aged care quality and safety, and the final report due for publication on the 12th of November of last year, following a 6-month extension to the report. And through the Royal Commission hearings, there were numerous reports of misuse of restrictive practice, including instances of isolation, punishment, seclusion and neglect. And there were families who shared their experiences with relatives who had been restrained in ways that were not consistent with their rights or had their dignity respected. That Royal Commission final report was released in February of this year, and this coincided with the release of that required review of the quality of care principles, which I mentioned earlier. And the Royal Commission final report advised that the regulation of restrictive practices should be informed by respecting and supporting people's rights, their dignity and personal autonomy, while also providing clarity around the circumstances in which restrictive practices could or should be used. That independent report into the quality principles made similar recommendations and was released at the same time. And as Melanie's already commented on, as a result, there were more significant amendments made to the legislation, which came into effect firstly on 1 July of this year and then again on the 1st of September, firstly which clarified and strengthened the requirements around restrictive practice use more generally, specifically around consent, and introduced a requirement for behaviour support plans as part of a care and service plan for an aged care consumer. So these changes reinforce the rights of aged care consumers in making decisions about their care, for their rights to be respected and for them to live with dignity and autonomy. The principles themselves are now quite prescriptive, and they act to ensure that when restrictive practices are used or when they're necessary to protect consumers from harm, they're used in ways that are consistent with their rights and also used with consent. This includes that restrictive practices must only be used as a last resort after all alternative strategies have been exhausted and the effect on that consumer has been considered. The legislative amendments also align the terminology, which Melanie spoke about, with the NDIS in the disability sector, which has been valuable for providers and consumers alike and has reduced confusion in the industry. In addition, the legislation now requires that any consumer for which restrictive practices are used, that service must have a behaviour support plan in place, which I mentioned before. The Royal Commission noted that overuse or misuse of chemical restraints can have significant effects on a person's health, including sedation, gait disturbance, increased risks of falls or fractures, urinary tract infections, incontinence and or constipation, increased cognitive impairment or confusion, increased risk of drug-induced movement disorders such as restlessness or agitation, and increased risk of respiratory complications such as pneumonia, heart rhythm abnormalities, cerebrovascular events including strokes, and increased risk of death. Significant adverse effects were also noted for non-pharmacological restrictive practices, including feelings of shame, fear, anxiety, loss of dignity, and increased risk of injury. So you can see that restrictive practices use, especially where this is inappropriate, can significantly affect the person's dignity and quality of life. Consumers who live in residential aged care are entitled to enjoy the same freedoms as the general community, including participating in decisions about their own care and having agency and dignity of choice as active participants in their care rather than as passive receivers of care where this is possible. This leads to behaviour management and supports regarding consumer-centred care, which can reduce or eliminate the need for restrictive practices, or where they are used, they're used as a last resort. And person-centred care is embedded in the principles and the aged care quality standards, and also linked with the Charter of Aged Care Rights. Person-centred care and behaviour management is about knowing the consumer as a person, understanding their history, their wants, needs, their likes, their dislikes, what triggers there might be for some behaviours, and the subsequent individualised strategies to support them and manage those behaviours. In persons with dementia, for example, behaviours are often an expression of unmet need. So is this person cold? Are they hungry? Are they tired? Are they thirsty? Are they bored? When consumers are known as individuals, including how they express their needs, the circumstances giving rise to their behaviour can often be met without the need for use of restrictive practices. By knowing consumers as individuals, aged care providers can respond with appropriate interventions and activities which have meaning for that person and which can reduce or eliminate the need for restrictive practices. This further improves their quality of life and enables care and services to be delivered in a way that treats each person with the dignity and respect that they deserve. Thank you, Nicola.
Thanks, Leonie, and I'm glad we managed to hold it together for you to give us that overview and that background. Thank you very much. We'll come back to Juanita now. It's actually quite a nice segue into Juanita giving us some more information and more detail about that fifth type of restrictive practice around chemical restraint. Thanks, Juanita.
Thank you, Nicola, and hello and good evening. I've been actively investigating inappropriate psychotropic use for some time, and when I started in 2007, I tried to avoid any reference to the word chemical restraint. I didn't want to imply that homes were using psychotropic medication deliberately to make residents easier to handle, and I have to say I couldn't really find a consistent definition. In the US, chemical restraint is defined as the use of psychotropic medications for various reasons, including for the staff's convenience, for discipline, retaliation or punishment, and I couldn't see any Australian service admitting to this. So it is contentious, and I avoided using the term restraint. But when I spoke to directors, they often volunteered that they didn't use any chemical restraint. For instance, in one Hobart home with over 100 beds, and that home also specialised in dementia care, they assured me there was not a single instance of chemical restraint occurring in their home. I'd just done an audit, and I found that over a third of the residents were taking antipsychotics, over 40% were taking regular benzodiazepines, and I remember thinking, not a single one. But then the Director of Care told me categorically that all the residents prescribed these medications had a diagnosis, and that diagnosis was mostly dementia. So to them, this meant that prescribing psychotropics was medical treatment and thus justified. Let's fast forward. We now have federal legislation which was introduced in 2019, which defines chemical restraint as a practice or intervention that involves the use of medication for the primary purpose of influencing a care recipient's behaviour. There are caveats that it says that chemical restraint doesn't include the use of medication prescribed for the treatment of a mental disorder, a physical illness or condition, or end-of-life care. So the definition is now clearer and it's consistent, but there are caveats, and I think it's still open to interpretation, and I'm going to talk about some examples of that. And that's where I think as pharmacists, as the experts in medication, we have a real role to play. I went to another service in July to regional Victoria when I was able to. They had 92 beds, and I asked to have a look at the psychotropic self-assessment tool there. There were 70 consumers listed taking psychotropic medication. Most of them, of course, were taking antidepressants, but about 20 of them were taking antipsychotics, 16 were taking benzodiazepines. And there's a column in this tool asking if the medication was prescribed for a diagnosed condition, such as a physical condition, an illness, or a mental disorder. Now, most entries for the antipsychotic had dementia written in a little box. Some of them had anxiety. I had 4 that had just a question mark, so there was no diagnosis even recorded. Now, the next columns ask what was the behaviour that led to the use of restraint. every single one of these boxes was listed as not applicable. So the home had decided that using a diagnosis of dementia or anxiety was not exempted that medication from being considered restraint. What was sad as well, there was a column that asked about consent, and again, not applicable. So in essence, the service thought that there was no chemical restraint used at all, even in those 4 residents with a question mark as the diagnosis. And I had this real sense of deja vu back to 2007, that there are still real issues when it comes to the interpretation of what is a chemical restraint. So I find it's really helpful to go back to the definition. First of all, that a chemical restraint is a medication used for the primary purpose of influencing behaviour. People say, well, what is behaviour? I was just going to plug an excellent new publication on behaviour support plans that's recently been released by Dementia Support Australia. I can't provide the direct link because you need to register. So if you Google Dementia Support Australia behaviour support plans, it's got a really good section on behaviour. And what they consider behaviours, or what we should be considering behaviours, are things like resistance to care, agitation, calling out, repetitive questioning, socially inappropriate behaviours, and sleep disturbance, to name some of them. Others are listed and described in more detail. Most of these behaviours occur in people living with dementia, but they also occur in people without dementia. And remember, if we go back to the definition, it says that chemical restraint doesn't include the use of medication prescribed for the treatment of a physical illness or condition. Now, dementia is not just one physical illness or condition. It involves a collection of symptoms, both behavioural and psychological, and often these behaviours occur in response to the environment or unmet needs, as Leonie was referring to as well. So when psychotropic medication is prescribed for the primary purpose to influence these type of behavioural symptoms, it's considered to be chemical restraint. I've also seen and heard and seen written as well the term anxiety used as a medical illness to excuse the use of benzodiazepines in particular. You hear that a consumer is agitated or pacing or displaying changed behaviour because they have anxiety. So what's happening is that anxiety is then considered a mental illness. So the service says it's not chemical restraint. But anxiety itself is a symptom. It's not a medical illness. So I was just going in the list of symptoms. I didn't mention psychological symptoms such as psychosis, depression, or diagnosed anxiety disorders. Now, we know psychosis occurs in about a third of people with dementia, and it can include hallucinations. I think mostly people with dementia have visual type of hallucinations, like small children, animals, or they can have psychosis which involves fixed delusions, such as that a spouse is cheating. I just wanted to tell you a story I just heard recently of a consumer in a service who had early onset dementia of a particular type, and she was convinced that she was being poisoned by the cook. So she totally stopped eating, didn't have anything to eat at all. So giving this person with a diagnosed psychosis or a fixed delusion an antipsychotic is not chemical restraint, as they do have a mental illness psychosis, even though it occurs within their dementia. But when the home, what happened then is the home asked the husband to sign a chemical restraint form with all the side effects listed, and they absolutely panicked because he spoke to a GP the day beforehand and they got his informed consent, and she hadn't mentioned chemical restraint. So correctly, it wasn't chemical restraint, but the home decided it was and then gave him a predefined form to sign. So when you go back to the definitions and the exceptions, it's not chemical restraint if it's used for a physical condition or illness such as Huntington's disease, which involves movement symptoms, careers, or for tics, and some neurodegenerative diseases. It's not chemical restraint if used for a mental illness such as depression, psychosis, a diagnosed anxiety disorder such as OCD, PTSD, or generalised anxiety disorder. Most of those would be treated by counselling and antidepressants in any case. It's not chemical restraint if the psychotropic is used in end-of-life care, such as midazolam and haloperidol, which is often delivered by a syringe driver. but these diagnoses must be clear and defensible on clinical grounds. The types of medications, coming to an end here, I could go on for a long time. The types of medication used as chemical restraint are usually used for their sedating or calming properties, and they include psychotropic agents such as antipsychotics, benzodiazepines, sedating antidepressants, antihistamines, opioids, anticonvulsants, and the list goes on. We've been hearing stories from homes that some GPs are saying that certain agents are not chemical restraint. I've seen on a piece of paper a GP writing Targan is not a chemical restraint. Targan is an opiate. But if it's used for the primary purpose to influence someone's behaviour, then it is chemical restraint. Any medication that sedates can be used as restraint. I just want to finish off by saying that in the Australian Pharmacist next month, I've written an article about chemical restraint, and I was assisted by Dr. Roth and also by an old age psychiatrist who's Professor Carmel Pisa, for those who'd like some more information on this topic and also on the new legislation. But I wanted to also finish by saying we realise that this area is very complex and it's very new territory, so we welcome any inquiries or questions that you might have. And on that note, thank you very much, Nicola.
Thanks, Juanita. That was a really good overview, and certainly I think it absolutely complex, and the different ways in which how you interpret this depending on the particular circumstances of individual patients, it really and residents, it really reinforces the importance of that person-centered care and really understanding the situation for each individual. So thank you. I'll just come back to Melanie briefly around taking all of this explanation that both you and Juanita have given us around restrictive practices and what that involves. If you are a visiting pharmacist to a residential aged care facility, what might be some of the things that you would look for? What might be some of the things that might cause you to be concerned?
Well, in response to that question, there are a few red flags that we can go into later, but I think what you are likely to find is that to varying degrees there is considerable confusion about what is and what isn't a restrictive practice among carers and service staff. There's certainly a tendency in some places to try everything possible to frame things as not a restrictive practice. And in some cases, as Juanita said, and it's not an isolated event, there's a perception that informed consent only applies to chemical restraint, which of course is not true. As you know, any medication needs consent, and this needs to be in proportion to the risks of the condition and the risks of the medication. And Dr. Chris Moy is going to go into this in a lot more detail, but an example of proportion is that somebody wanting a Panadol for a headache, it would not need a high level of consent given the low risks and the general understanding of the medication, whereas higher risk medications or even interventions, and I'll give examples of warfarin, any psychotropics, and of course surgical interventions would need a much more robust process. So it doesn't matter whether it's a restrictive practice or not. The restrictive practice scenarios was suggested reading for the webinar, and I believe there's been a link sent to you, and I would imagine that many of you have not had a chance to read it. But we developed those probably a couple of years ago now to give context and to give a structure to the thinking around deciding what is and what isn't a restrictive practice. We've updated it with the new terminology. But we developed it to try to guide the thinking in a context, and we've given several people, pretend people, but really situations which I'm sure any of you who've worked in aged care will readily recognise. And it not only says some of the strategies and some of the lead up, but it also explains why various things are or are not a restrictive practice. So I think it's a useful tool for understanding. It's quite an easy read, a little bit, a few little soap opera episodes. And it's also good to draw people's attention to if they are struggling. So we've given some very specific examples. There is some tendency to think of a device being a restrictive practice rather than the use of it in each individual. And an example is that bed rails can in fact enable people's free movement if they're using it to put their hand and lever themselves out of bed. And it's certainly not a restrictive practice if it's an automatic one that a person can operate independently themselves. But they can be highly restrictive if the purpose is to keep somebody in bed when they're desperate to get out of bed. And they're certainly not without risks. So if the question is a bed rail a restrictive practice, or is risperidone a restrictive practice, it's actually the answer has always got to be, it depends. And I'm just going to give you a few little summaries of some of the scenarios. So the first one is Ronald, who's got a background of chronic schizophrenia. He's managed by his GP with regular reviews by his long-standing psychiatrist. His medication is risperidone. This is not chemical restraint because the medication is to treat a diagnosed mental condition, schizophrenia, and Ronald is consenting himself. There's Maria, who was diagnosed with dementia 4 years ago, and she's taking donepezil, Aricept. She recently transitioned to a secure residential service due to wandering from her home at night, becoming lost and becoming aggressive with family members. So staff are very vigilant, preventing her leaving the facility. Maria's GP is also asked to help with agitation and distress. The GP assesses her and suggests trial of a low dose of risperidone. Now, in this case, although Maria has a diagnosis of dementia, the risperidone is prescribed to manage her behaviour associated with dementia. It is not a drug to treat dementia itself. The donepezil she's taking is the drug to treat dementia. The risperidone is not. Rather, it's being used to manage the associated behaviour. And this is a particular area that people struggle with. They think that BPSD justifies the use of restraint, which has not been restraint. And I like to use the analogy of a brain tumour where somebody is given Panadol, somebody with a brain tumour is given Panadol to manage the pain, but Panadol is not a drug that would treat the brain tumour. And the same thing applies to risperidone with dementia, unless, as Juanita said, there is a true psychosis associated with the BPSD. Jeffrey's been in his residential service for many years with vascular dementia. He was placed in a locked service against his will. So initially that was clearly a restrictive practice. However, he's progressed significantly and now he's bedbound, and he's making no effort at all to get out of bed. He's really got no independent movement and he's now non-verbal. So the secure unit is no longer a restrictive practice for Jeffrey because it's actually his condition that's restricting his free movement, not the service in any way. It wouldn't matter where he was. Donald has got mild dementia and is wheelchair dependent. He'd like to go out of the service for a change of scenery and to do some shopping, but the staff often don't have time to facilitate this and it's upsetting to him. So he is being environmentally restrained. The locked environment, as well as his impaired mobility, are interfering with his free movement to do what he wants to do. Anne has dementia. She's begun to wander around a lot more and has been getting into other people's beds. She calls out frequently and is awake for many hours at night. The GP prescribes both regular diazepam and PRN risperidone in case she's having a particularly bad night. Now, both of these drugs are being used as chemical restraint in Anne, even though in the case of risperidone it is only PRN. So that's another misconception, that if something's used PRN, it kind of doesn't count. However, as you well know, it is used with, in some places, gay abandon by people who really don't understand the harms that it can do, or even the context in which it's meant to be used. And this is clearly where your skills will come in. And PRN is definitely a flag. PRN use of an antipsychotic is definitely a flag for chemical restraint.
Great. Thank you for those examples, Melanie. They're really useful, I think, I know that they're not real people, but they're really useful for people to get a sense of actually what this might mean in practice. And I think what you've been talking about consent leads us nicely into the next part of this, introducing Dr. Chris Moy, who's a GP from Adelaide and currently Vice President of the AMA. Chris, as a practicing GP, what does consent mean for you?
Yeah, you often see consent as a little tick box in some form, and I think sometimes we take it as rather a frivolous matter. But look, as time has gone on, and I think I realise it now, that people misunderstand it and probably don't take it seriously enough. The bottom line, it is the fundamental basis of everything we search for in terms of individual autonomy or self-determination. I mean, it's embedded in things like codes of conduct, Human Rights Act, and the Charter of Aged Care Rights. But ultimately, it's about me being able to say, as an individual, yes or no, with the right information to treatment that I'm going to be offered. Now, I'll read a definition. This is from the Australian Commission of Safety and Quality in Health. Informed consent is a person's decision given voluntarily to agree to healthcare treatment, procedure or other intervention that is made following the provision of accurate and relevant information about the healthcare intervention and alternative options available, and with adequate knowledge and understanding of the benefits and material risks of the proposed intervention relevant to the person who would have been having the treatment, procedure or other intervention. Now, look, that seems pretty straightforward, but there is actually a kind of a logical process that you need to go through. So as a doctor, I need to go through this logical process in actually obtaining informed consent to be able to provide a treatment for a patient. And excuse me if I call individuals patients, I'm talking from a doctor's point of view. Look, the first thing you've got to do is you've actually got to determine who will provide informed consent. And that's got to do with the clear line about a thing called impaired decision-making capacity. Now, so if a patient has decision-making capacity with respect to a particular decision, obviously that patient is the one to make the decision. If a patient has impaired decision-making capacity with regards to a decision, then this really does need to go to a substitute decision-maker, and usually in each jurisdiction, there's going to be a consent hierarchy, a list of, in descending order of who has the greatest power to be able to provide informed consent on behalf of the patient. So that's the first thing. You need to work out who it is that actually provides informed consent by determining whether the patient has impaired decision-making capacity. So then the medical practitioner has the key role, and their job is to offer treatments that they believe to be of medical benefit to that individual. Now, it's not their job. It's common law principle. They don't have to provide everything. And some doctors do not understand that. What their job is to do is to offer treatments that they will be of benefit, medical benefit to that individual. And in that, consider wishes that may be expressed in things like advanced care directives and advanced care plans, because they will actually give an idea of what that it is likely that that patient would benefit from. And that includes key decisions about things like end-of-life treatment or things that the patient really has really a great problem with and does not want, or things that are of great value to the patient, such as dignity, for example, being a really key principle. The next thing they need to do is to explain the risks and benefits of each option provided. What is going to be helpful, but what is going to be the problem of each treatment? And many of these things have been discussed today with regards to restrictive practices. And they need to do it, ensure and be clear that that individual has been provided with information in a manner which is understood. At that point, and obviously it's a toing and froing, but the role of the patient or the substitute then comes into play. And I think there is a responsibility for a patient or a substitute, and the medical practitioner should encourage this, and that is that the individual should clarify what they don't understand. And obviously to set the scene to be able to do that is very important. And then the key part of it is to say yes or no to that treatment. Obviously it's going to be a lot easier if it's the individual themselves, but if it's the substitute, they really should be trying to do this on the basis of what we call substitute decision-making standard. That is, they should try to do what the patient would have wanted had they been able to make the decision themselves, put themselves in the shoes of the individual and try to make the decision based on what they understand to be the values and the wishes of that individual. So that's kind of where you go. That's informed decision making in a nutshell. Now, there are some key aspects of this that I think people should understand. A decision can be independent or different to what the doctor believes to be best for the patient. I mean, that's a really important thing. There are many decisions that are made where that you may feel is the best decision for a patient, but that patient can decide to not do that. And it also may include refusal, which may lead to harm or death to that individual. For example, individuals are allowed to refuse to have interventions which can prolong their life. But you should, I think it's a very good principle at that point, you should clarify why they don't want that treatment. A patient or substitute maker cannot demand treatment that is of no medical benefit. That's a common law principle. They just can't demand treatment. I mean, otherwise we'd have people demanding to live forever or to die on the Queen Elizabeth II, unreasonable expectations, especially in COVID. But that's not being unreasonable, in that you still do need to offer treatment that you believe is genuinely of benefit to that individual. You've got to obtain consent. You must obtain consent from a patient or STM unless there's an emergency and no one else is there to provide informed consent. There are emergency situations where the patient can't provide you with consent because they're unconscious, for example, and there is no somebody else. In those situations, there is the out to provide emergency treatment. To fail to obtain consent or to go against a refusal is essentially assault or tort of trespass. In simple terms, if I walk up to you and I don't get consent before I stick a needle in your arm, I'm assaulting you. And that applies right across the board. Individuals can change their mind and withdraw consent, and that's important to understand. And getting back to what Melanie said, obviously there is a thing called implied consent. I mean, and obviously you do need to consider the consequences of the treatment. I think Panadol might be a very low risk type medication where the risks are going to be relatively low, and often the patient would have given you implied consent, or the substitute would have given you implied consent that for something that's simple like that, that's okay. But then things like psychotropics are going to have a much higher bar, and that's what you need to consider in terms of ensuring that you obtain and document informed consent, particularly when pretty much in any situation, but definitely if there's any contemplation of this concept of chemical restraint. And our pharmacists have a key role in all this. They do need, and I think it's very helpful for them to provide information to patients and help them identify the effectiveness and side effects and interactions of medications. And that may mean that patients may change their mind about a treatment, and it's very helpful, for example, with medication review to do that. And I think that's a particularly good role so that patients or their substitutes can actually get a better understanding of why treatment's being provided, and as I said, individuals can change their mind. And I think the other thing is that pharmacists have a very key role to recognise that poor compliance of a medication or a medication refusal may represent a significant withdrawal of treatment, and it's a very good thing to then interact with the medical practitioner in terms of actually re-evaluating the reasonableness of the medication and whether in fact proper consent was obtained in the first instance. So I hope I've given you a bit of a rundown about consent, and it makes some sense.
No, that's been really useful, Chris. And just as a bit of a follow-on question for that, from your perspective, are there particular issues for aged care residents around capacity and consent? It's a complex area.
Well, it's complex, but it's critical because decision-making capacity is the line that determines whether the individual has to provide the informed consent or somebody else on their behalf. And the first thing is that a lot of people think of decision-making capacity as something that is a medical diagnosis, or it's a level, or it's that's dementia, they don't have decision-making capacity, or that it's a blood alcohol level, the person's too drunk to make a decision. It's got nothing to do with that. It's not a medical diagnosis. It is actually whether they can do certain things. Now, decision-making capacity, the important thing is also to understand it's presumed. Everybody starts from the presumption of having decision-making capacity first. You do not take it away unless there is evidence to the contrary. It should be supported if at all possible, and residual capacity should be able to be respected. And, some people can understand some things, but not others. And also fluctuating capacity should also be respected. Other time you may be able to catch somebody at a time where they can make a decision another time. The other thing is that impaired decision-making capacity only relates to a particular decision when consent is required. So it's got this issue about if the decision, because a lot of people can make a decision about their stamp collection, although not many people have stamp collections anymore, but they can make a decision about their stamp collection, but they cannot make a decision about very much more complex matters, such as, complex health matters if they have no insight, or, for example, if they can't, financial decisions. And I think the key aspects of decision, and I think of it very in simple terms, I get lots of letters from lawyers saying, does this patient have capacity? And look, it's really quite simple. Decision with respect to a particular decision, impaired decision-making capacity means an individual cannot do one of four things or several of four things. So to be able to make a decision, you have to be able to understand the relevant information, retain information for long enough to make the decision, use the information to make the decision, that is to apply, weigh up the risks and benefits, and then communicate the decision in any manner. If an individual fails in one of those, then they have what we call impaired decision-making capacity with respect to that decision. And that is the line. Once you've actually determined that, that's when you may need to get go to somebody else to get informed consent for a decision. Now, in different states, if you've determined that somebody doesn't have has impaired decision-making capacity, then you have to decide who will make that decision. And Melanie, it's now codified as substitute decision maker. But in different states, every jurisdiction has a different hierarchy, who the next person is along. Somebody appointed as officially a legal decision maker, substitution maker, but there may be other people who are implied down the line, like relatives or others, if the individual doesn't have that. It's important that this is specified in principles in relation to restrictive practices, but it applies to all medication and treatment. I mean, decision-making capacity really should be something you should be thinking about in all of those areas. And as I said, I hope you now understand a little bit about the idea of decision-making capacity and then the need to determine that to be able to work out who you get informed consent from. So, look, I'm going to pass on to Craig now, who will talk about OPAN resources developed to illustrate these concepts for consumers.
Fantastic. Thank you, Chris. So introducing Craig Gear, who is the CEO of OPAN, the Older Persons Advocacy Network. Craig, initially, can you give us a bit of an overview about OPAN for people who may not be familiar with the work that you do?
Yeah, sure, Nicola, and thanks coming to you tonight from the land of the Gadigal people of the Eora Nation. And I just want to say the pharmacist, I think, is so important in this work around consent, but also around the medication cycle. And every health professional, including the consumer, the older person, and their family has a role in this. OPAN is there to support older people. We work on their behalf. We work to make sure that their rights are upheld. We make sure that their voice is actually heard in these decision-making processes as well. And our organisations are in each state and territory, and they've been doing this for about 30 years. I noticed, I think Nancy had talked about a family being pressured by a GP to go to a particular pharmacist. Nancy, I think this is an absolute example where you'd call 1-800-700-600 and ask to give that number to the family and ask them to get an advocate who can go into to basically help them to navigate that with the facility and with the GP. So we're there for the rights of the older people. One of the key rights that sits within that Charter of Rights is around the right, number 5, to be informed about care and services in a way that I understand. And what we're talking about here in consent is absolutely about that, and holding up that right, number 5, for older people and and pharmacists being part of that to raise that up for people.
Thanks. And so we've had a lot of conversation tonight, Chris, about restraint and about consent. So what about the work that OPAN has particularly been doing about consent? What are your views around this issue, particularly from the consumer and the advocacy perspective?
Absolutely. And Chris touched on a lot of that around supported decision-making, which is a position that we really promote. And the pharmacist could ask, who actually did do the consent here? and did that person have fluctuating cognition, so that they could have been brought in to say, hey, what's their pattern and what did they say of wanting these sorts of medications in the past? Has someone had a conversation with that person? Has someone had a conversation with the family? And some of the work we did with the Commission, with Chris, with Juanita, was actually to put a package together that actually explained some of that and how to ask those questions. And ask those questions in a way, I suppose, that also helps for it to be a safe conversation. Sometimes people don't want to make a fuss. They think the doctor knows best. Sorry, Chris. Most times they do, sometimes they don't. And that's why we have a lot of people in the care medication cycle to actually question and make sure that this is done safely, and pharmacists are so important in it. So opan.org.au/your choice. There's an explainer video there. There's a set of resources that pharmacists can give to families, can give to the residents, and that actually explain all those things about what it is to give valid, informed consent. It's medication is someone's choice. It is also someone's right to actually make decisions about that. So it's really important. Use those resources. Hopefully some of you have seen that. But consent is really there to protect that human side, to make sure that decisions are being made with you, not about you, without you. And finally, I remember Teresa Flavin, who spoke to us about this, in a situation where she had some cognitive decline, but actually at times she just needed someone to support her in her decisions. And she said, though, one time someone forced medication on her that was sedative, it was restrictive practices, and just the feeling of having that power taken away from her. And it's so important that we all be part of this to actually make sure that consent's given, that it is, but put ourselves in the person's shoes, or what that would be like. Really highly recommend going and using those resources. So thanks, Nicola.
Thanks very much, Craig. And we'll see if people don't already have the links to the OPAN resources, we'll make sure that you get that so that you can follow up those, because they're really very useful and great for you to share. I'm going to go back to Juanita now to kind of just wrap up a little bit and talk about what we've talked a lot about consent, about the importance of it, and when it needs to be given, and different circumstances. Juanita, from your perspective, is there anything that a pharmacist can do if he or she believes that consent for a medication has not been given? What's the options and roles of a pharmacist in those kinds of circumstances?
I think first of all, that pharmacists really need to realise that it's a consumer's basic right to consent to any treatment. But it's within a pharmacist's duty of care to ensure that a service follows its legislative requirements. But it's not only legislative requirements, it's also ethical requirements. I would point out to the service in this case that the new principles really say that before any medication is used, that informed consent should be gained. And with regards to chemical restraint or restrictive practice, the assessors are going to be checking whether informed consent process is followed. Pharmacists can also help this informed consent be gained. They can ensure that there are good consumer brochures that outline benefits and effects, and they're available to help relatives make this decision, but also that the prescriber can use them or the home can use them. The Commission have some excellent resources. The NPS Medicine Wise have some good consumer brochures. OPAN has some, and Dementia Australia have some. But I think it's really important to encourage this, residents and relatives to really ask questions when we do qualities of medicines activities, or when we conduct medication reviews. Encourage them to ask questions about their medications, and if you sense they've got doubt about a certain medication or whether they should take it or not, really direct them to the prescriber and say it's their right to ask questions. And I just want to finish by saying that informed consent isn't only sort of applicable to medication decisions in aged care. It also applies to the pharmacy programs, RMMRs, HMRs, with access to records. And we're hearing often that homes are asked to gain consent from residents and relatives on a pharmacist or a pharmacist service behalf. But I would ask, is this truly informed consent? Do the homes really know about the services? Are they able to give really detailed information about them and what's performed? So it's really across the board, sort of really putting informed consent as part of really patient-centred care and good practice.
Yeah, thanks, Juanita. I think that's a really useful way of ending about the importance of informed consent, about thinking about each person as an individual and providing care that is appropriate for them. Okay, we're just about out of time. But we've got our next webinar in 4 weeks. Melanie, what are we going to expect in that next webinar?
So the next webinar, we are hoping to talk about the pharmacist's advisory role in governance in residential aged care, about all things pharmacy. We'll talk about medication advisory committees or MAC committees, and we'll also speak about community pharmacy programs. So that'll be the third one.
Excellent. Okay, fantastic. So that'll be in about 4 weeks' time. You'll hear about the details. We've had lots of questions in the chat tonight, but we're just about out of time, so we won't be able to get to those. But in the same way that we did for the first webinar, we will come back to you with answers to those questions. So there's lots of really good stuff in there, and I'm sure that the answers will be very useful for everybody. So I just want to say thank you to our panel tonight, to Leonie, Melanie, Juanita, Chris and Craig. It's been another very informative and useful webinar, and thanks for your participation, and thanks for everybody who was part of the webinar tonight. We'll see you again in 4 weeks' time. Thanks.